Good morning, everyone. Welcome to Neurology Grand Rounds. It's my pleasure to introduce our speaker today, Dr. Alexandra Coria. Dr. Coria is a pediatric hospitalist at Maimonides Children's Hospital in New York City and founding executive director of the Maimonides Medical Center Global Health Institute. Her career in global health spans 18 years, during which she's participated in myriad global health initiatives in advocacy, research, and program implementation in the United States, Haiti, Tanzania, East Timor, Guyana, and elsewhere. After graduating from residency in the urban health and advocacy track at Boston Children's and Boston Medical Center, she worked for the Baylor International AIDS Initiative in Tanzania, providing medical care for children with HIV. She later returned to academic pediatric hospitalist medicine, teaching and mentoring residents interested in global health, first at Boston Children's and now at Maimonides. Her primary interest is in global health education, through which she hopes to foster equitable and ethical global health practices among the next generation of global health professionals. It's my pleasure to invite our speaker today to address the audience.
Thank you so much for that introduction. And I am very excited to be here. I will caveat this by saying what you have undoubtedly already understood, which is that I am not a neurologist. And we are going to talk about a little bit of global neurology, just a very small amount. But the fact is that, I've been working in this field for, as it said in my bio, 18 years. And global health from the last many decades has been really dominated by maternal and child health. So we're going to talk about, that's why we're going to see so many maternal child numbers, but we're going to tie it back to neuro, don't worry. So what I am really here to talk about today, though, isn't global neurology. It's really about every physician's practice and some thoughts that I've been having in the conversation that's ongoing in the sphere of global health and health equity about how those things are very tightly linked. And I'm going to take you on a little bit of a whirlwind history of global health so that we can understand where all this talk about health equity that we're all hearing all around us right now comes from. So without further ado, at the end of this talk, I hope that you will be able to describe in general terms the connection between global colonial history, systemic racism, and implicit bias in medicine. I hope that you'll understand what it means to decolonize medical practice, and you'll be able to list a few ways that you can work to decolonize your own practice and provide more equitable care to your patients. So I like to frame this talk around the top 3 questions that I get when I say I work in global health. The first one is, oh, so you work with Doctors Without Borders? The second one is, have you ever been to Africa? And the third is, what's global health? I am not sure what you're talking about. So I'm going to answer those questions for you today, and I would also invite anybody that has questions or comments as we go, please feel free to put them in the chat. I am looking at it. So I'm going to answer these 3 questions for you today. But before I get into that, I think it's really important that we're all on the same page about what we mean when we say global health. So I'm going to give you a little bit of history here. Global health is really comes from at its origins a different field called tropical medicine. And tropical medicine was sort of in vogue, I would say, around the turn of the 20th century, so the late 1800s into the early 1900s. When we saw projects such as this one, which is a picture of the building of the Panama Canal, really start getting going in the colonial sphere. So we had Western powers that were trying to take advantage of economic opportunities in countries all around the world. Now, the Panama Canal, there were 22,000 people died in the building of the Panama Canal. It was so costly in terms of human life that the French actually completely abandoned the project at one point. So why is this important to us? Because what we think of as the eminent schools of public health, like the London School of Hygiene and Tropical Medicine, like the Harvard School of Public Health, these were founded around this time, not necessarily to serve the interests of health equity, but just to address these problems of how to increase economic gain from massive infrastructure projects, mining projects, et cetera, in colonized countries. So the main reason that people died in the building of the Panama Canal was because of yellow fever and malaria. So a Western British institution took up the cause of solving those problems of yellow fever and malaria, not out of the goodness of their hearts, but because of the economic incentives to do so. So that's really important. So that was the first part of the 20th century. The second part, the sort of middle part of the 20th century, saw this transition from tropical medicine, which was very economically driven, into international health, what people started calling international health. There was a little bit of a change in nomenclature, because what we saw was the advent of organizations like Doctors Without Borders, or as we call it, the French name is Médecins Sans Frontières, which we call MSF. So when you hear me refer to MSF. So this is a really interesting organization. I'm going to tell you a little bit more about them in a second, but this was the era when we started seeing more aid organizations, and the WHO started having more public health activities, more big public health interventions to decrease morbidity and mortality globally. This is the Smallpox Zero campaign, which is another example of that. And this is also the time in the middle of the 20th century, as most colonized countries were emerging from their colonial economies, that we also see the advent of the medical mission. So people going on medical missions were very well intentioned. It doesn't necessarily, but there wasn't a lot of thought necessarily about what the people that they were going to help. It was usually Westerners going to ex-colonized countries to try to help in places where there was poor infrastructure or limited resources to improve health outcomes. But there wasn't a lot of thought about what people in those countries may want or need, or how to make those interventions sustainable. So we saw a lot of fly in, fly out, go and, give out medications and then leave again without following up what they did, which is problematic in some ways that we really realize in retrospect, and was really put a fine point on by Megan Vaughan in her book, Curing Their Ills, Colonial Power and African Illness, in which she said healing for medical missionaries was part of a program of social and moral engineering through which Africa could be saved. There was a real paternalistic bent to these medical missions in the middle part, and even ongoing now today, some of them. The middle part of the 20th century. So although it's a humanitarian idea, it's still very paternalistic and a very neo-colonialist approach, rooted in the assumption that Africa needed saving, without much acknowledgement that the resource disparities, lack of education and infrastructure were not a result of an inferior culture or economy, but of the vast and systemic violence that had been done to colonized countries by the West, among other colonizers. So this impulse is not bad to help people who need help, but it was not bad people who were taking part in medical missions, or who still do that today, but this attitude that drives medical mission work is worth exploring, which is a lot of what we're going to do here today. So with that, I will get started answering these questions for you. So question one is always, do I work for Doctors Without Borders? I can't tell you how many times I've gotten this question. Obviously, no, I work for Maimonides. And I probably never will, because Doctors Without Borders is not an organization that does exactly what I do, but you might. So it's worth knowing something about them. So Doctors Without Borders, also called MSF, is a really cool organization. It was very innovative in the 70s when it was founded. It was the first emergency response and advocacy organization to take a totally agnostic view to where people needed help. They were the first organization really to ignore political and religious affiliations and just go where they were needed most, which is still what they do today. They go and help in places where war has destroyed infrastructure, where their health infrastructure, and where where natural disasters have taken place. So they are a really critical resource to the global health community that does a lot of good work. which is why it's interesting that in the midst of the COVID-19 pandemic, MSF actually opened its very first mission, they still call them missions, in the United States. One of the most highly resourced countries in the world. This is really unusual for them. And where did they go when they were looking for a place in the United States that needed help with infrastructure because of resource issues and public health challenges? They came to Brooklyn. They went to Brownsville in East New York to help shore up the vaccination infrastructure there, which was really struggling, and as we know, was very hard hit by the pandemic. So this is super interesting. Why, of all the places in the entire country, would MSF open a project in Brooklyn? There are a lot of reasons for that, and I'm just going to talk about one. So the one thing that is unignorable when you look at this, at what they decided to do, is that East New York and Brownsville are dominated by populations that descend from colonized or enslaved people. So anything that's blue on these pie charts, which is the vast majority of the chart for those who are just listening, though, this is a population that's descended from a colonized or enslaved population. So the segments of the population in green have significant have strong histories of colonial oppression, or they descend from enslaved people. This is the legacy. This right here is a legacy of the European colonial era in this country, that the areas of our own city that are hardest hit by the global COVID-19 pandemic are also the ones that bear the most scars of the global colonial era by way of slavery, exploitation, imported disease, and generations of post-colonial political instability. These problems don't go away because you live in a different country. They're inherited by your descendants. So this is not a coincidence that this was the hardest hit part of Brooklyn. And we know that this pattern holds true over the entire country. You have undoubtedly seen this data or data like it. The thing that I find most striking about these data, which define the increased risk in minority populations compared with white populations for disease and death from COVID-19. The thing that I find most striking about this is that if you look at these numbers for the Black population, you actually see a 1 times relative risk in late 2021, a 1 times relative risk of actually getting COVID-19, but the risk of hospitalization and death is much higher. So 2.6 times higher for hospitalization and almost 2 times higher for death. So, and the CDC says why they think this is down here, that race and ethnicity are risk markers for other underlying conditions that affect health. And it's really important to consider that why when you're thinking about this data. So, so to get back to MSF for a second, so they came to the United States to open this project there. And at that same time, while they were doing really amazing work among disadvantaged populations and hard-hit populations all over the world, they were also struggling with this problem, which is super interesting. So The Guardian in 2020, in the midst of the pandemic, published this article saying that people who worked for MSF were calling them out as being institutionally racist. How does that make sense? That this organization that lives for health equity, its sole purpose is to improve health outcomes among in challenged health systems, is being called out for being institutionally racist. How does that make sense? Well, what the article says is that in 2019, MSF employed about 65,000 staff, about 90% of whom were hired locally in their 70 country offices. However, most of its operations are run by European senior managers out of 5 operational centers in Western Europe, with only one, which opened in 2019 in Senegal, located in the Global South. The Global South being a euphemism for lower and middle income countries. It goes on to say that there was an almost suffocating white savior mentality, one staffer said, while others complained of recruitment policies that pushed staff with 10 or 20 years experience to be supervised by fresh graduates. I will say that this situation, although somewhat shocking, is not that surprising to anyone who works in global health. This is a very pernicious problem in many global health institutions. I left a job because of exactly this issue. So I think it's really worth exploring where this white savior complex comes from and why it is so rampant in this aid organization that is supposedly committed to promoting health equity. So where does it come from? I think we have to look at our history. Remember the London School, one of the institutions that drove the first forays into international health tropical medicine. Remember that the work the London School started, looking for solutions to health problems in tropical countries, that work is grounded in colonialism and is the precursor of the global health work that goes on today everywhere. This at the first graduation from the London School, my slides are not advancing. Sir Patrick Manson, the founder, said, "I now firmly believe in the possibility of tropical colonization by the white race." This is what he was shooting for. This is white supremacy at its best. If you trace the colonial roots of global health, the reasons that this white savior mentality persists in our organizations are clear. This is where our field was born. And this is also where many of the leaders of many organizations still are trained. And I will make the point here that it's not that anybody at the London School is going around teaching white saviorhood, right? Everybody is teaching about health equity. Everybody is thinking about how to improve and equalize health outcomes. But there is an element of implicit absorption of these messages that does persist and is nobody's fault today. But when you have people who are trained at Harvard, Johns Hopkins, the London School, these other huge institutions in the West, leading initiatives in lower and middle income countries, there is a certain amount of implicit bias that they come through their training with. And all we can do is be humble about that and ask ourselves why constantly. Okay, so I'm going to give you a couple examples that illustrate this implicit bias in the field of global health, public health. So not everything that has happened in global health is a tragedy in the mid-20th century. One of the really important things that happened, and anybody that's interested in global health should definitely know about, is the Alma-Ata Conference. So the Alma-Ata Conference espoused health for all by 2020. That was the mission. There were 3,000 delegates. They were from 134 countries. This was in 1978 in the USSR. And it was this grand coming together of people from all over the world to try to find solutions to some of our stickiest public health problems. And what they came up with was this. They reaffirmed that health is a human right and a primary responsibility of government, not of international NGOs or the WHO, but the country government. They really emphasized community engagement and health program design. They re-emphasized the importance of community health workers and highlighted successes like China's barefoot doctors who were embedded in rural communities and vastly improved health outcomes in China. And they really focused on the sustainability of health systems. So these are all great messages, but the problem with the Alma-Ata Conference is that it had no teeth. So people went home feeling really good, but nobody quite knew what to do next, and there were no enforcement mechanisms. So about a year later, in Bellagio, Italy, people came up with this idea of selective primary health care in response to the Alma-Ata Conference. This was based on the work of two Western researchers who published a paper called Selective Primary Health Care: An Interim Strategy for Disease Control in Developing Countries. The participants, there were only four organizations: the Rockefeller Foundation, which is American, the World Bank, the United States Agency for International Development, and UNICEF, which is the UN Children's Fund. So there was no representation at all from lower and middle income countries, even though they were there to talk about problems prevalent in lower and middle income countries. And what they came up with, again, not bad. So they found, and this is where we see that real emphasis on maternal child health and global health at this stage. They came up with 4 interventions that they thought, if we could fully implement them, would vastly change health outcomes in lower and middle income countries. Growth monitoring, oral rehydration solution for diarrhea, exclusive breastfeeding, and immunizations. And so this sounds great, but quickly this strategy came up against some obstacles. So first of all, growth monitoring sometimes meant monitoring with no intervention if you found poor growth, because there are a lot of other resources you need to address malnutrition and poor growth. So that became an immediate issue. They did not take into consideration that oral rehydration salts can't be mixed in anything if there's no clean water, so that doesn't work. They've failed to take into consideration that at this time, Western formula companies were making a major marketing push in lower and middle income countries and spreading misinformation about the health of formula. So they were coming up against a huge barrier there in the breastfeeding campaign. And then the one real unequivocal success was the immunizations. Those campaigns continue today and are considered to be a very impactful intervention. So these are not bad things, and every project meets challenges, but you have to ask yourself, if anyone had been at that table who was a member of a population where these interventions were targeted, would they have been able to anticipate some of these issues? Would they have chosen different areas to focus on? We'll never know. And more importantly, why didn't the people at this meeting think that anyone from the populations primarily Black and Brown, primarily ex-colonized, where these interventions were targeted, why didn't they think any of those people deserved to be at this meeting? Why did they think that they didn't understand their own problems? That's worth thinking about. And then there are also much more blatant examples of racism in global health. So this is Andrew Natsios. He was the head of USAID at the turn of the 21st century. When the AIDS epidemic was ravaging the sub-Saharan Africa. And he made an argument to the US Congress not to send antiretrovirals to Africa. So this is the head of the United States Agency for International Development saying, we can't send antiretrovirals to Africa. And the reason he gave is that Africans do not know what watches and clocks are. They do not use Western means for telling time. They use the sun. When you say take it at 10 o'clock, people will say, what do you mean by 10 o'clock? So first of all, I went to Africa a few years after this, and I can say for absolutely certain that they definitely know what watches and clocks are. It was the year 2001, so that's ridiculous. But also, the last time I checked, if you've been doing it your whole life, watching the sun is a perfectly legitimate way to tell what time it is. So, but he was not the only person making this argument. This was a big debate among Western donors to whether Africans could take ART. So Amir Adiran just decided to test the theory, and he found that using the customary definition that good adherence means taking ART as prescribed 95% of the time or more, 82% of Africans succeeded at that goal compared with only 55% of North Americans. So basically they're blowing us out of the water, and by this logic, we should send all of the ART to Africa. So, this is sort of a funny story in the history of global health, funny and a little tragic, but just really goes to highlight, when you don't ask people and when you make assumptions about what you make some really big errors in judgment. So why are we talking about colonialism here today at Neuro Grand Rounds? Because global colonial history is the root of the implicit and explicit racial bias today, which leads to premature closure and false assumptions about the care we give, even among well-meaning people. And this is really critical. I am not trying to say that anybody is explicitly racist or trying to do bad things. What I'm saying is that when you don't ask the people that you're trying to serve, you come up with false assumptions. And when you don't take a hard look at the assumptions that you are making and the biases that you might hold, then you're not going to be as good a doctor. So that's the first reason we're here talking about this today. All right, so the second question that I get asked is, have I ever been to Africa? The short answer is yes, many times. It's sort of beside the point to why I work in global health, but I do understand why people ask it, which is because of this. In 2007, Save the Children collected data on where the highest child mortality in the world was, and they found that 98% of child deaths occur in lower and middle income countries. And they also identified they identified 60 priority countries, which are all the ones in orange, for interventions to slow child or to improve child survival. And they found that 10 countries with the highest number of child deaths actually made up more than 60% of child deaths, these countries in dark orange. So so it's not surprising that people, when I say I work in global health, they ask me if I've ever been to Africa, because I'm a pediatrician, and most child death, it's like where people think of, with good reason, when they think of child death, sadly. So but I like to take a little bit closer look at this map, because I see the countries in orange, certainly, but, and I specifically see that these countries in dark orange here in the middle of Africa and in the Indian subcontinent, these were the places where the colonial history was particularly brutal. If you don't know anything about the Belgian Congo, I suggest you read the book, King Leopold's Ghost. It will give you a really good understanding of what happened that means that this country is just was behind from the start. So in any case, I look at this and I look at the orange, but I also look at the gray. And what really jumps out to me here is that almost all of the high mortality countries are ex-colonies, but no, zero Western ex-colonizers are high mortality countries. So that's sort of interesting, right? I think it has a lot to do with resource flows, economics, and history. And this pattern of disease burden, where ex-colonized countries suffer more disease burden, and I will say here also China is a special case that, you know, it's on the map, but I know someone is thinking that. So, but when this pattern persists across most fields, except interestingly for neurology. So neurology, so this is data from 2019. It's disability adjusted life years per 100,000 population. So disability adjusted life year, for those who don't remember from their epidemiology class in med school, is the amount of time that's basically taken off your life by disability. So so we see the highest number of disability adjusted life years attributable to neurologic disorders, excluding stroke, in Western countries and in richer countries. Does anyone have anyone who's able to type have any theory about why this might be? You probably honestly understand this phenomenon better than I do. What I have read in preparing for this talk is that the burden of neurologic disease is often greater as people age and as they suffer other health problems like hypertension, although that's related to stroke specifically. But and also when you have a population that has aged sufficiently, you see a greater burden of dementia. And then when you have more diagnostic sophistication, you really start being able to evaluate for neurologic disease better. That is my impression of why this map looks the way it is. There's probably subtleties that I'm missing, but it's interesting that this is the one field that where this pattern is reversed. And I will say that data was collected that's data from 2019, and all of that data was collected in service of what we call the Millennium Development Goals, which is this icon down here. Now, the advent in 2000 of the Millennium Development Goals is really what most people probably think of as the start of the modern era of global health, where we really started talking about global health rather than international health or international medicine. And what the Millennium Development Goals were a set of 8 broad goals that really represented a return to the principles of Alma-Ata and primary health care. These goals acknowledged that the colonial area was extremely exploitative, decimating economic and social systems in colonized countries for generations. And the point of them was to narrow the development gap between high-income countries and lower and middle income countries, including specifically focusing on health outcomes in 3 of the goals. I will say there were no specific targets between 2000 and 2015, the period that this covers, in neurologic outcomes. That came to light later. But by and large, a lot of progress was made. We got 13 more million people on antiretrovirals. We greatly reduced child mortality. And the world's governments really committed a lot of resources to these goals. But after 2015, after the MDG era, this is when the world really starts to pay more attention to the burden of non-communicable diseases, including a lot of neurologic and developmental disorders. We start to appreciate the burden of dementia and neurocognitive disorders and realize that if anything, the incidence of stroke in lower and middle income countries is growing as people start to suffer less from infectious diseases and develop more diabetes and hypertension. So I'm actually just going to transition to a different window quickly so that those of you who are watching along with me we can play with some data together, because that is something I love to do. So let me see if I can. I'm having troubles. Okay, so let me just share the other screen here. Okay, so this is data on neonatal encephalopathy due to birth asphyxia and trauma. So this is where our two fields come into combination here. And this is regional data, so collected at the regional level. The top bar is the rate of death attributable to neonatal encephalopathy in the African region. The second one is the Eastern Mediterranean region. And then this one is the Southeast Asian region. So 3 regions that have a lot of lower and middle income countries in them. So and we see over the period, so in 1990, we had started to make some progress on these goals. But in 2000, when we started talking about the Millennium Development Goals, we start to see an acceleration in the rate of decline of neonatal encephalopathy, death from neonatal encephalopathy. And by 2015, we've made great progress, which is amazing. And that progress continues today. So very exciting. However, something interesting happens when you start looking then at the downstream effects of that increased survival, which is that right where we see that inflection in the downward inflection in the rate of neonatal death, we see a huge upward inflection in these in the rate of severe intellectual disability due to neonatal encephalopathy. And the other thing, the other graph that looks almost exactly the same is epilepsy due to neonatal encephalopathy. So what we're doing here, we're creating a population, and the effects are disproportionate in Africa. I am happy to say that due to improvements in birth practices, we've now started to turn this curve downward again, although the pandemic really messed with that. But what we're doing is we're saving these children to live lives with disability, with epilepsy. And so that creates an entirely different burden of disease for the world. And the point that I want to make here is really that that these countries that have this history of extreme exploitation, these countries don't we can't fix it. You know, it's not. It's never going to be. They're never going to be, there's still going to be high levels of need, even if we make a lot of progress on the actual birth outcomes. We just sort of create NCD problems, non-communicable disease problems. So I am now, okay, so, all right, let me just go back to my presentation here. So so that data is really striking. The fact that, and it's something that I think people didn't really think about. And one of the reasons that we've started thinking more about neurologic and developmental outcomes, at least in pediatrics, since 2015. So it's great that we have all this data, and it's really interesting to see these patterns, I think, and correlate them to where we know there is a particularly brutal colonial history. But right now we're looking at a country level, right? But we're physicians, and I just want to actually make sure I'm sharing the right screen. Can't tell. Okay. Yes, I am. Okay. But we're physicians, right? So we see all of this data, epidemiologic data is super interesting, but we treat people one by one. So why do we care so much about these broad patterns, and how does this apply to us on an individual level? The UNICEF had the same question in 2011, and what they decided to do to get at some of this individual level determinants of health was they took all of the child mortality data in the world, and they pulled it together, and they disaggregated it not by country, which is how it's reported, but by social determinant of health. And what they found was that persistently across every country in the world, we see some pretty striking patterns. Which are summarized here. So what this data shows is that, and I've lost my mouse, sorry, I'm having some technical difficulties here, but that's okay. So when you are a member of the poorest 20% of the people in your country, you are more than twice as likely to die before the age of 5 than the richest 20%. The mother's education data always really gets me. So if your mother has no education, you are almost 3 times as likely to die before the age of 5 than if your mother has a secondary or higher education, not even college education, just high school. And then if you live in a rural area, you are twice as likely almost to die as if you live in an urban area. This is really problematic here with the mouse. Okay. Okay. So let's see if I can advance this way. Okay, sorry, everyone. Things seem to have frozen here. So, oh, here we go. Okay, we're back, I think. Okay, sorry, everyone. Yep, I can't seem to advance the slides. Oh, here we go. Okay, all right, we're back. So what Anthony Lake, who was the head of UNICEF at the time that this analysis was done, what he said was, if you disaggregate the data, we find that our statistical national successes, remember that dramatic decrease in neonatal mortality, are masking moral and practical failures. People who are left behind simply because they live in rural communities or urban slums, in conflict zones, as part of indigenous groups, with disabilities, or because they are girls. So what he's saying is that we've really got to look deeper than the country level. We have to disaggregate data at the community level, at the individual level, and really look at people's social determinants of health to reach that last population that's contributing to those high mortality rates and high disability rates. And we know in our country that people who descend from ex-colonized and ex-enslaved people have worse health outcomes. So I would ask you to consider, again, why are race and ethnicity risk markers for other underlying conditions, for the social determinants of health? Remember that when you look at this data, American Indian and Alaskan Native people are the colonized populations in our own country. Black people descend either from populations who were colonized or people who were enslaved, mostly. And then many Hispanic and Latino people descend from colonized Native populations as well, although that history is not quite as clear-cut. And on top of that, we know that when we control for socioeconomic status, these disparities persist. So the social determinants of health go far beyond just the situation that people are living in this moment. Mistrust, generational trauma, and other factors also contribute to these numbers. So why are we talking about colonialism? Because the colonial era resulted in vast economic and social disparities that persist today and have been transported across borders, often manifesting as social determinants of poor health in those descended from colonized and enslaved people in our own country. So this is a very, very sticky, pernicious history. Okay, so this one I'm going to try to move through fairly quickly so that we have a little bit of time for questions. Sorry, the technical difficulties got my rhythm off, but so the third question I get asked is what is global health? And this is the definition that I really like the most, which is that it's an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. So you have probably seen a diagram like this or some at some point in your medical training where we compare equality and equity. And I just want to make those definitions clear again so that we know what we're talking about. So equality is having an equal resource, so everybody gets the blood pressure medication. Equity is giving people who need a little additional help in order to use the blood pressure medication the help that they need. So if you, like, this kid can't use this box, right? We're giving him the wrong help. We have to ask him what he needs before we can give him the chance to look over the fence and have an equitable outcome. So that's the difference between equality and equity, which is really critical to understand. So that is what global health is. I will say that global health is also a field that is currently undergoing a reckoning. The COVID-19 pandemic really made all of our work toward health equity much more difficult and also much more important. Resource disparities were exacerbated all over the world, with ex-colonized and ex-enslaved people disproportionately affected everywhere. In terms of our practice in global health, those foreign staff were pulled back off into their home countries. And what we found is that programs gained more autonomy in local operations. And we started thinking about how much we are really needed, us foreigners, to lead country offices, to lead projects in lower and middle income countries when there are people on the ground who understand the context much better. We also started, as you know, using much more virtual education everywhere. And then an interesting thing that happened is that global health practitioners were often called on to lead the response in the US. And we found that we had to lean on our collaborators from resource-deprived places a lot to manage the resource challenges that emerged in the COVID-19 pandemic here. We used the lessons from Ebola to design contact tracing strategies. We had to collaborate more across borders than we ever had before. And for me, what was the most interesting was that I found that I needed to call on the experience and expertise of my colleagues who work all the time in lower and middle income countries where there are resource shortages to help people manage the moral distress of having to allocate ventilators, for example, which is a situation they had never been in before. So there were a lot of changes to the way that we think about global health. And to help you really understand how the pandemic really turned global health on its head, it's important to once again recall this trajectory towards the modern way that we practice. We started really reflecting on how global health partnerships function, what their goals are, and how they could be more respectful and frankly less racist. And what we have come to the conclusion is that for most people working in my field is that we need to just detach ourselves from this history. And we started hearing calls to decolonize global health, such as this one, which is an article written by two scholars, two very important voices in global health, where they say, even today, global health is neither global nor diverse. More leaders of global health organizations are alumni of Harvard than are women from low and middle income countries. A crucial first step in recognizing that ours is a discipline that holds within itself a deep contradiction. Global health was birthed in supremacy, but its mission is to reduce or eliminate inequities globally. To transcend its origins, global health must become actively anti-supremacist and also anti-oppressionist and anti-racist. Equity and justice involve flipping every axis of supremacy on its head. So why are we here talking about colonialism today? Just to recap, number one, Global colonial history is the root of our implicit and explicit racial biases, which lead us as physicians to premature closure and false assumptions, even when we're well-meaning. It's not our fault that the colonial era happened, but we love our patients, and this history is extremely pernicious. The second reason that we're here today is that the colonial era resulted in vast economic and social disparities that persist today and have been transported across borders, often manifesting as the social determinants of poor health in those people descended from colonized and enslaved populations in the United States. And the third reason that we're here is that decolonizing global health means acknowledging and addressing drivers of systemic oppression everywhere on the globe, including in our own practice. So if I'm working toward health equity globally, New York is on the globe. I have to think about my practice here. So this is what I asked you to do next. First, remember that most patients who are Black, Indigenous, or people of color are in a social context that reflects generations of oppression rooted in colonialism. Please be proactive about addressing the social determinants of health, which are the reflection of that history. And then before going abroad to do global health work or global health equity work, please do your homework on the organization's approach and make sure that they are actively anti-racist. Okay, but specifically what you can do, I have some specific tips for decolonizing your everyday practice. So first, understand implicit bias. Know what we mean when we say that and start to reflect on your own implicit biases. This is a really good tool at implicit.harvard.edu to get some interesting information about the way your own brain works. The thing about implicit biases is that they're implicit. We don't know we have them. So you have to work to try to find them in your own brain so that you can provide equitable care to your patients. Ensure your patients understand their treatment plans. Teach back can really help patients overcome power disparities like the one between patient and doctor. It increases adherence, it increases health literacy, and it helps align you with the patient. Imagine being a person who doesn't speak medicalese and in addition might not even speak English. Your doctor is talking at you. You think that you understood what they said, but the only way to verify is to talk back at them. And you're really afraid of saying something wrong because this is a person that you really respect and whose opinion you really value, and you don't want to make them mad at you. And they have a lot more power in the situation than you do, power to reject you, power to judge you. And that is really uncomfortable. So you as the physician, you have to elicit that teach back. You have to make the patient comfortable telling you what their questions are or what they think their treatment plan is. Please do that. Always use an interpreter, not the patient's child, not their parent, not their spouse. I once again just ask you to put yourself in the position of that patient who can't really speak English very well, and you can't speak except through a person who you're not sure understands medicine as well as an interpreter would. So lots of patients decline interpreters, and that's okay. That's their right. Although you also, as a physician, have a right to an interpreter, by the way. You can tell the patient, I want to make sure that I am well understood, and therefore I want to have an interpreter present here in case there's a miscommunication. But if you don't use an interpreter at all and you depend on somebody's 12-year-old child to interpret for them, you are really putting that person in a position of minimal power and not promoting equitable care for them. So please always use an interpreter. And then again, I'm harping on this power thing, but physicians are a very powerful element of society. So if you have an issue that you would like to speak out on using legislative advocacy, you will be listened to. And that's a really important thing to recognize. And then at the individual level, please screen for the social determinants of health. Talk to your patients about what their barriers are to adhering to your treatment plans, and refer appropriately to social work and community organizations, if you know what they are, to help them overcome those barriers. So people don't not want to adhere to your treatment plans. They often just aren't on the same page as you about what's important, or they have some significant barrier in their personal life that they are dealing with. So I am going to stop there and see if anybody has any questions. And if they don't, then we can do a little bit, just a really brief exercise, but I would really like to know if anyone has any questions. please feel free to just unmute.
Can I start with a question, please?
Of course,
And
yes.
a comment. First and foremost, I want to thank you for a wonderful, thought-provoking presentation. And of course, being from India and an ex-colonial, I understand this very, very well. And only now Indians are waking up to all the atrocities committed on us. Okay. Next is moving on. I love Dr. Tutu, South Africa's bishop, who again put it very succinctly, saying, he said, we cannot undo the injustice, but we have to face it. So he said, it's truth and reconciliation. And again, the reconciliation has not happened in America. So that's why we are struggling with, the inequalities, but to be able to acknowledge and to say, hey, we move forward. The last part of my question is, again, has gotten me thinking. I spent 40 years of my professional life serving the children of Brooklyn. I'm Dr. Giri Dharana, or Dr. Giri, pediatric neurologist. So I'm a kindred spirit in taking in the pediatrics part with you. Having done, I said, I have still a few more good years. How can I help the children of Brooklyn? And so I started a Brooklyn Children's Society because I felt the children in Brooklyn need more help. And so, but again, luckily not paternalistic, but was this maternalistic? Was this again a wrong thought on my part? Or how do I handle this and move forward? How do I become mindful is what I want to ask you.
I love that question. So I don't think that it's ever wrong to want to help someone who has need. So I definitely don't. Thank you so much for asking, because it gives me the opportunity to just reiterate that I never want to say that your inclination to help someone who does not have the resources or the power to help themselves, that's never wrong. I think the really important thing, though, is to understand what help means to that person, or to that society. And that's something that we really emphasize is community-based needs assessment in global health, is just going to a community. You may have some idea of what people need. The last project that I started, we went to meet with a hospital in Guyana that was interested in partnering. And we had this whole idea about implementing an early warning score system on their inpatient unit. And we had a whole plan. We had talked about it briefly with them. But when we really sat down and said, do you need this? They said, we do, but what we need more is safer discharge planning for our kids with asthma. And we said, oh, well, then, of course, we'll work on that with you. We have the resources to do that too. We have the expertise to help you with that also. And so it was just a really clear-cut example of when they even knew what their resource needs were. And they, because we hadn't really asked them effectively, maybe we hadn't asked them enough times or in the right context, we didn't know what they needed. And children know what they need. People who don't speak English know what they need. Recent immigrants know what they need. They might have, they might take suggestions because what you can offer that they might not understand. But I think
in this situation, what we have set up is for people to ask for, to apply, put in an application saying what their need is. And so then we review it and we say, okay, this meets our criteria and we give. Is that a way to, balance our good intentions to make sure that they are getting what they want?
I think so. I think as long as you're really, truly, honestly engaging with the people that you're working with, that, everybody's doing the best they can. And you're just paying attention to what the people that you're trying to help value. Because also, I've been in many situations also where I think I'm doing good work. And then I come to find later that everybody is, just ignoring the things that I'm doing or not collecting the data I want because they're like, why is she doing this? We don't want this. That's an experience I think everybody who works in global health has had. So that comes right down to the individual level too, asking your patients what they need, what they value, considering I recently read that we should interact with every patient as though they represented a culture of one, with, you know, where they understood individually what their pressures and values are. And that's what we should take into consideration when we talk about working cross-culturally or taking into consideration somebody's different culture. So everybody is a culture of one.
Thank you so much.
Thank you. And I think we have 1 minute left if anyone has a quick question.
Brian and Ziska, I just want to correct one thing. I'm from South Africa. I immigrated to the United States in my early 20s. I think one has to differentiate between the different colonial powers. The British, with all their racism, which is true, believed in a fundamental fairness. For example, Black people were given the vote in South Africa, at least in the Cape Province, in the mid-19th century. Unfortunately, before South Africa became independent in 1910, the right of Black people to sit in parliament was abolished. And of course, this all led up progressively to apartheid. The only saving grace was the sort of concept of British liberalism, which still existed, at least in the English-speaking universities, which were multiracial and admitted non-white people. So I think one has to look at each country differently. Obviously, the Congo was the worst example of colonialism in Africa. I just want to contrast this with the United States, where 3 constitutional amendments obliterated racism as an official political fact. Nevertheless, with Reconstruction, it all came back, and one had a system of apartheid in the United States well into the 1960s. The mistreatment of Native Americans is well known and persists. The Indian Health Service is underfunded, and I think the American colonies have largely been failures, especially the Philippines, in terms of independence and fairness. And I think the United States really is not any better than the European colonial powers were.
Oh, no, I definitely would not. I do not want to give anyone that impression. We have our own stuff to deal with in the United States. And I have heard this viewpoint from several South Africans. I will say, talking about racism and colonialism. I think it is, I do definitely think that it's necessary to think about every colonial power as a different entity with different policies, different methods of oppression, different economic consequences, socioeconomic consequences. And that's just way too much to get into in this talk, but your point is well taken. And I think that part of what I hope people come away from this with is an understanding that when we talk about global health and we talk about colonialism and the impact of colonialism, we are not talking about out there. We are very much talking about right in here at home. So we're past 9 o'clock. I'm happy to hang out for a few more minutes if that's okay, if anybody else has questions or comments, but otherwise I very much thank everyone for listening, and I hope that I gave you some food for thought. And Dr. Brosgall asked whether there are propositions to switch from paternalistic to a maternalistic approach. I have never thought about that question quite that way, but I will, and I will get back to you. Thank you, everyone.
Thank you.
Mm-hmm.